Okay, well, I guess it's just the two of us. Riley is Zooming today, so. The two of you, not the two of us, whatever. So, okay, we're going to continue our discussion on breast cancer here in chapter, whatever it is now. We're in the repro chapter. Let's go ahead and bring this up. Okay, we were talking about breast cancer the other day, and we see this is a PET, a PET scan of the left breast, and it has metastasized from the breast into the cervical lymph nodes and potentially into the mediastinum in the middle of the chest. You can see the glowing areas. You can see the kidneys outlined in the ureters and urinary bladder. We don't tend to pay attention to that because that's where the dye tends to show up. So what we're looking at are these glowing areas here. There's a suspicious spot here in the axillary lymph nodes. But what we're seeing here is that this tumor has started to move around or started to spread, and we don't like that. But again, this type of imagery doesn't tell us that it's a cancer. The only definitive way to tell it's a cancer is a biopsy, where we have to get a sample of the tissue. Now, the needle biopsy is the easiest. You simply insert a needle into the breast to guided by ultrasound to where the tumor is located and take some cells out and examine them. The needle biopsy is the simplest. The more complicated procedure is the open biopsy, where you actually make an incision into the breast and take out a lump of tissue that includes the suspicious area and the tissues around it. So over at the breast center at LeConte, they actually have an examining table that is designed for the patient to lay flat face down. And so the breast can protrude through an opening in the table for the biopsy. So this way, my wife told me I had that done a number of years ago. She has some sort of calcification in her right breast, and it pops up on the mammogram every year. And they went in and took the samples, and they left a little clip behind that shows up on the x-ray, so they know that's exactly where it is. So, and it was just calcification, but you don't take any chances on that. It was relatively painless. It was awkward, is the best way she described it. So, okay, now we have to use ultrasound to find the lump. You just don't go sticking around in there hoping you're going to get it. And you can't just take a picture like this of a mammogram and say, well, I think it's going to be here. So we use ultrasound to follow the location, an ultrasound probe to go with the needle, and we simply aspirate a few cells, and then the cells are immediately examined by pathology. Now, the other approach, which is if it is to take out an actual cube of tissue surrounding the suspicious lump, examine the whole area, make slides of everything and examine the entire section to see if it is malignant. And if it isn't, then great, you've gotten rid of it. And if it is malignant, you've also gotten rid of it, and you may have gotten all the cancer too. So there's an upside to that. The scar, it's very minimal. If you notice on the right breast, left breast, you can see the scar next to the areola. It is almost invisible. So it has no, it is not like the drastic consequences of having a mastectomy or something like that. So let me okay. Now let's go on. Treatment. Treatment has evolved over time. In the 70s, the standard treatment was to remove the breast do a radical mastectomy and take off the breast and everything around it and the lymph nodes and the pectoralis muscles and everything that was there in the hopes that if you removed everything, you could stop the cancer from growing. And sometimes it worked and sometimes it didn't. It just depended on whether or not the cancer cells had started to metastasize, started to spread. If you caught it before they spread, that was great. If it had already started to spread, then you were having to deal with the lymph nodes and go on from there. That procedure has evolved into what we call a lumpectomy, where you simply take out a lump of tissue, including the tumor. And if the cancer has not started to spread, then you have caught it all, and your patient's very fortunate. Because the thing about breast cancer, just like any other cancers, you don't know if it's going to be a slow grower or a quick grower. You don't know if it has spread yet or not. So you try to take the minimalist approach and see if that catches everything. And if you've caught everything, that's great. If you have to take out more tissue, then you go into what's known as a simple mastectomy, where you take out the breast tissue and the axillary lymph nodes. Some of these involve simply leaving the skin intact and taking out the tissue underneath. Since the cancer tends to grow in the ductwork, in the milk ducts, it doesn't seem to affect the skin if it's the most common type of cancer. So you have you've removed the cancer, you remove the cancerous tissues, and you have a structure for reconstruction. So this is what we call the skin sparing mastectomy, where you take out the cancerous tissue underneath the skin and leave the skin on the surface, so you can rebuild with a prosthetic. So that's why they call it skin sparing. You have this is what they call the keyhole incision, where you go in. It's sort of, I would say it's almost like laparoscopic surgery. You go in, remove all the cancerous tissue, and you retain the skin and left that behind. So total mastectomy, you take off the breast, you take off the lymph nodes all the way up to and above the muscles above the ribs, the pectoralis muscles above the ribs, and you end up with a scar, where the breast was. The radical usually takes off all of the pectoralis muscles. You can see how, this is a person that's had this would say it's a truly disfiguring procedure, but it is done because if the cancer has spread, you see there at letter E, we're now into the cervical lymph nodes too. So we take out all the axillary lymph nodes, and we take out the pectoralis muscle and any other tissue that might possibly be affected. And of course, the modified radical is simply just the breast itself and the lymph nodes. There's all variations on this now. This is what it looks like. This is what your patient will look like afterwards. You end up with, you can see that the pectoralis muscles are still intact underneath the skin. Those bulges underneath the scarring, but there's nothing else there. The breast and all the associated tissue, including the lymph nodes, because you can notice that the scar goes all the way around to the back. The lymph nodes have been removed too. And here we see a total mastectomy. Here, this is again, this one is a total mastectomy, but what you've got is enough skin left behind to rebuild underneath that scar. So, okay, and the decision on what kind of treatment is going to be made by your patient Whether or not they're going to opt for any reconstruction, it depends on how they view themselves, whether they think it's important or not. You know, there's all sorts of parameters on what kind of treatment that they opt for. There's all variations. If it's caught early enough, it may not require certain types of surgery, or they may opt for surgery. I've known people that have opted for bilateral mastectomies where both breasts are taken off simply because of a family history, you know, where their mother and their cousin and their grandma all had breast cancer. They don't have any hint of it, but they take this proactive view. Let's avoid the potential for it. And so they do. So, okay. Moving on into female sexual response. When the female is sexually aroused, you will see an increase in blood flow, just like you see in the corpus cavernosum and spongiosum in the penis. The clitoris will enlarge with blood. It will become engorged. Blood will come in at a faster rate. We will see an increase in nitric oxide, causing what we call vasodilation, meaning the blood vessel, vaso means blood vessel, dilation means to enlarge. So the blood vessel is going to enlarge and causes blood flow to increase. So we're going to see the clitoris enlarges, the vagina, the mucous membranes of the vagina enlarge, the breasts enlarge, and the nipples become erect, just like the clitoris will become erect too. The vestibular glands will lubricate the vagina and the vaginal orifice and the vestibule. Now, what this leads up to then is the increased sensitivity of the clitoris. You know, again, it's analogous to the glans penis. The clitoris becomes about 10,000 times more sensitive to touch than any other place on the body. And this mechanical stimulation will ultimately, if it continues, will lead to orgasm. You know, it is the heart rate goes up, the breathing rate goes up, blood pressure goes up, muscle tension, the smooth muscles of the pelvic floor will contract rapidly. There will be a tremendous sense of well-being. We will, during orgasm in males and females, we release the hormone dopamine, you know, and endorphins. It's the pleasure hormones that we encounter. Same hormones there that we also release when we eat chocolate too, by the way, just to throw that out there. Same hormone, really. It's probably why people like to eat chocolate so much, you know. Many people like chocolate, some don't, but many people do. And some people crave chocolate, and it's probably the driver of the same release of hormones on a slightly smaller scale, you know, so which might explain that. Now, so we see at orgasm, the uterus contracts rapidly, smooth muscle contractions. The contractions go outward. The vagina contracts outward, which is sort of counterintuitive because, you know, during intercourse, you know, during ejaculation in the male, the semen and sperm are ejaculated into the uterus and into the vagina and make their way into the uterus. The contractions are pushing against all that. So all of this is taking place at the point of orgasm. Now, males have something called a refractory period after orgasm. And that is the amount of time it takes to recover so they can achieve a second erection followed by another orgasm. Now, some males, you know, a younger male in their teenage years have a very short refractory period, and so they can achieve an erection very quickly after the first one and engage in intercourse again and have a second orgasm shortly after the first. Because typically what happens is the erection goes down after intercourse, and then the male has to become stimulated again And a younger male can have a refractory period in minutes. An older male, a very older, much older male, has a refractory period measured in days. So it sort of controls when the erectile tissue in the male can become engorged with blood again, and with arousal. Females do not have a refractory period. Females are entirely capable of having multiple orgasms. Males aren't. Males have an orgasm, they have ejaculation, and then they're done until they become stimulated again and become aroused. Females can have multiple orgasms during one experience. Furthermore, a very common misbelief is that you have to have an orgasm. If you don't have an orgasm, you can't get pregnant. That conception doesn't occur without an orgasm. So that's not true. Pregnancy occurs when the sperm cell penetrates the egg, whether the female had an orgasm or not. So that's another one of those wives' tales that we have, one of those urban myths, or just let's just say a myth about health that we sort of have to remind our patients that no, it doesn't necessarily have to happen. So the female sexual response, arousal is something that takes place very similar to the male. It can be both by touch and psychological, meaning some sort of visual or verbal stimulus in here. Thoughts, just like in a male, can start the the female sexual response. What will happen is all those things that we'll see blood flow increase to the clitoris, to the vagina, to the vestibule, and to the breast. The vaginal lining is lubricated. The vagina actually enlarges in here. The labia move apart. The vestibule is lubricated. As I said, heart rate and breathing go up. The muscles become tense, and the nipples become erect. And there is a certain amount of, it's broken down into 3 phases that sort of correspond to the males. We have the excitement phase, where the female is initially aroused. The heart rate and breathing rate go up. The skin flushes. There's a redness that spreads up, usually from the area below the breast up into the throat, and then eventually towards the face. The nipples will harden almost instantly. In here, they tend to get the increased blood flow right away. And the vaginal wall will tense up. The genitalia will start to swell. In the plateau phase, the clitoris withdraws. It pulls itself back underneath its own glands. The vagina is lubricated. The vagina may turn purple. Every time I say that, I have to think that somebody had to be examined so they would know that it turned purple. There are muscle spasms during this point of excitement. And as it says, there are vocalizations may occur. If trying to think, if you ever saw, anybody, you ever watched The Big Bang when it was on? You never watched Big Bang? Okay, you ever see that movie, Harry Met Sally? Ever see that one? Well, you guys are useless. So, okay. There were just 2 good examples of vocalization of a woman who was sexually aroused in there. And it was, both of them were comedies, so they weren't like something you shouldn't be watching, but they were examples of the sounds a female can make when she becomes sexually aroused. She doesn't control that. It's a perfectly normal occurrence. So if your patient says, I make funny noises when I'm, engaged in intercourse, well, that's okay. You can make your funny noises. So, okay. The orgasm is the shortest of the phases. It only lasts for a few seconds. It is the heart rate goes up and then spikes and it comes back down. There are more sounds. There's more muscle spasms. There's a sudden. There's a very dramatic release in tension, and then the euphoria is caused by the release of the dopamine neurotransmitter and the endorphin neurotransmitters. These are the feel-good neurotransmitters. Dopamine is the neurotransmitter that is our feel-good. It's our mood stabilizer, and the endorphin is our feel-good, if you will. We release lots of endorphins when if you remember from AP1, we talked about strenuous exercise, and you feel good after strenuous exercise. That's the release of endorphins. If you eat chocolate, you get a release of endorphins. During intercourse with an orgasm, you release endorphins. Endorphins make us feel good. And then we have the resolution phase. Everything returns to normal. The muscles relax. The blood pressure drops. It's very normal to become sleepy. There is an intense feeling of intimacy. And of course, in the resolution phase, it is still possible to achieve multiple orgasms in here. So, and many of your patients will question whether that's normal. And it is. It's perfectly normal for that to occur. Okay. As I said, females have no refractory period like the male does. And so, there is no recovery period that they have to wait through before they can have a second or a third or a fourth orgasm. The sex drive in the female patient, in your female, is driven by the androgens that her adrenal cortex is producing. This is the female libido, the desire for sex. The adrenal cortex is producing this. The inner layer of the adrenal glands, the zona reticularis, is producing these androgens. The androgens are going to be the driver. And you'll find that your postmenopausal female, your patient who has just finished menopause, menopause is defined as going a whole year without a period. So that is considered menopause. In your postmenopausal patient, they will often find that their sexual desire is higher than it was before menopause. And that's because now the androgens are not being blocked or overwhelmed by the estrogens that the ovaries were producing. And it is these androgens that are going to drive the desire for intercourse. And it's not uncommon for your early postmenopausal female patient to say, I have a greater desire for sex than I had before. Is there something wrong with me? Because it's unusual. It's different for them. So, and you just explain what's going on. So, but there is something else that's taking place during menopause. While the libido is driven by the androgens, the libido is sort of depressed in here. Typically, what happens is in a woman of fertile age, pre-menopause, not meaning that she's about to start menopause, but in all the years leading up to menopause, when she is sexually aroused, it's because of desire for sex. So sexual desire triggers arousal. She'll become aroused and then she'll have the desire. After menopause, it's just the opposite. Desire for sex will usually occur after they become sexually aroused. It sort of flips. The libido doesn't seem to kick in until after they're aroused. Part of this is that the vagina goes through a certain amount of atrophy. It shrinks, it becomes drier because the estrogen levels are low. So the vagina is no longer as lubricated during arousal. And so with less estrogen, we have reduced blood flow, we have to the vulva, the clitoris, the vagina. So the, your patient will often say that they it takes longer to become aroused than before, or that they become aroused and then they have a desire for sex. And again, there's nothing wrong with that. It's just how their bodies are functioning now. It sort of flips it on its head as to what's going to take place. Now, males are different. Males will probably have a desire for sex from puberty till the day they die. Males, it's often been said that the average male thinks of sex every 7 seconds. I don't know if that's true or not, but males seem to function because males don't lose their sex hormone production. Like when a female goes through menopause, she loses, her ovaries shut down and she's not producing estrogen anymore. And that's going to be, driving all the other structures here. That alters how she becomes aroused and has desire. The male, on the other hand, continues to produce testosterone from puberty till death. And so males don't have this issue. But just because an 85-year-old male can produce sperm doesn't mean he should be becoming a father. Okay. Mentioned this earlier, older adults and sexually transmitted infections and diseases. Believe it or not, more than 80% of adults over 50, between 50 and 90, are sexually active. We know that because we see that patients over 60 have the greatest increase in sexually transmitted infections than any other age group. The 15 to 25-year-old age group has been pushed aside by the 60 and above group. If you look at the numbers here about herpes, look at herpes, gonorrhea, syphilis, hepatitis B, trichomoniasis, and chlamydia. These cases, the cases of those were in 2000, between 2014 and 2017, there was a 23% increase in all these sexually transmitted diseases for in that time frame for people over the age of 60. Compare that to those over the age of 13, and it's only an increase of 11%. So, so older adults are engaged in riskier sexual activities than the adolescent and early and young adults are. So all of these STDs are treatable, but it seems like in the older adults, the need to protect themselves and their partner from STDs is why bother? Okay, so let's take a look at this. STIs. Apparently the name has changed from an STD to an STI. The old name from World War II and World War I was called a venereal disease, or VD. Then it became an STD. Now it's an STI, a sexually transmitted infection. The US leads the world in sexually transmitted diseases, despite the fact that there are some very simple means for protecting individuals. Condoms are probably in the 90% and above area in protection, simply because these bacteria and viruses can't get through the condom in most cases. Nothing is 100% effective if you're looking for protection from an STD or an STI. The problem with these STDs is that they cause disruptions and disorders and infections in the reproductive tract. Now, one of them can kill you. Syphilis can kill you. All the rest can simply interfere with reproduction by blocking the reproductive tract. Trichomoniasis and what was the other one? Herpes may or may not interfere with the reproductive tract, but it definitely makes it less desirable to have intercourse. Let's take a look at some of these here. So chlamydia, gonorrhea, and syphilis have all gone up since 2016. We can thank the older American age group for that spike in these diseases. Chlamydia, a bacterial infection, is the most common, about 1.6 million. Chlamydia is similar to gonorrhea. Gonorrhea has been around for a long, long time, and now it's making a rise too, and so is syphilis. The old standby sexually transmitted diseases that have been around for forever, gonorrhea and syphilis, are now having an uptick in here. So chlamydia, most common STD in the United States. It causes pelvic inflammatory disease. Bacteria grow in the uterus and in the fallopian tube, and they grow and reproduce in there, and they cause scarring to occur, and they block the fallopian tube, so an egg can't get down to the uterus, or sperm can't get up to an egg. There are some very definitive symptoms here. It hurts to pee. The urethra is inflamed. There may be a discharge from the penis or from the vagina. The discharge is usually clear to white, so it makes it hard to notice. There may be pain. It may hurt during intercourse. The female may have, her period may occur 1 month, and then the next month it may be 6 weeks out. Or she may spot, or she may have a heavy flow. Or maybe none of these. It can cause urinary tract infections in males. It can also increase the risk for arthritis. In the newborn, it can infect the eyeball and cause the cornea to get scarred, and it can lead to some sort of respiratory infection. It looks okay. So we see the gradual increase from 2000 to 2016, and these numbers just continue to climb. In all of our STDs, we see the greatest numbers tend to be in the South. We see that the states that have the fewest cases of these are outlined in gray. We see that West Virginia is sitting in the middle of a hotbed, but they must not be having a lot of sex in West Virginia, or they're just not reporting it well because it's all gray. So, but the numbers keep going up. It is the most common type of STD in the 18 to 25-year-old range too. Yeah. Okay. So since it has some dramatic numbers in the South, where does Tennessee stand? Well, our cases have not increased much per 100,000 population. So that's the good news. But we are still much greater than a lot of the other states. Now look at West Virginia. They, in 2016, they only had 4,800 cases compared to Tennessee's 32,000 cases. North Carolina has 64,000 cases in 2016, and 58,000. And Texas had 143,000 cases. So it's just all over the board. This is what it can do. It can cause scarring on the cornea of the eyeball. It can cause bacterial growth. We see here the bacterial growth in the mouth on the left, and inflammation. As far as the reproductive tract goes, we see a clear discharge. It's hard to catch this, hard to notice this when we're examining a patient, because your patient may not notice a clear discharge. What is so obvious about a clear discharge? How do you notice there is a discharge? So whether it's from the urethra in the penis or from the vaginal orifice, it's hard to notice this discharge. But that's part of one of the symptoms. If we look at it microscopically, chlamydia is a rod-shaped bacteria. It's a pathogenic, tends to stain purple. But when it grows in the fallopian tube, you see what it's doing here. Those are clusters of chlamydia, and it causes scar tissue to form, and that scar tissue can eventually block the fallopian tube.
So chlamydia is gram-negative. Chlamydia is gram-positive.
Yeah, purple positive pathogenic is sort of it's not 100% reliable, but nearly always. If it's purple and it's gram positive, that part's true. If it stains purple, it's gram positive. Gram negative stains pink. Yeah, so if it's purple, it's positive, and it's usually pathogenic. It seems like there are more pathogenic bacteria that are gram positive than there are gram negative. So not always, but mostly. So, but gram positive bacteria will always stain purple. Now, somewhat similar to chlamydia is gonorrhea. Gonorrhea has been around for a long, long time. It goes back to the Middle Ages. Chlamydia probably did too. We just probably didn't notice it. The bacteria is Neisseria gonorrhea, commonly called the flat. That's the familiar name for gonorrhea. It can infect the genitalia, the rectal canal. It can affect the mouth and nose, anywhere. Fortunately, chlamydia and gonorrhea are both treated by antibiotics. While we have 1.5 million cases of chlamydia, we only have about 500,000 cases of gonorrhea. Now, the symptoms in the female, the urethra hurts, it's inflamed. I'm sorry, in the male, the urethra hurts, it is inflamed, it hurts to pee, and you get a greenish yellow discharge. Can't miss this. It's this greenish discharge coming out of the urethral orifice. In females, she may have this discharge too, but often she has no symptoms at all. Same with chlamydia. However, gonorrhea will also cause scarring to occur in the uterine tubes and lead to pelvic inflammatory disease, and can also cause sterility or infertility by blocking the uterine tubes and growing scar tissue around the ovaries. So with chlamydia, you can't see, the discharge is clear. It is a clear discharge. In gonorrhea, it's a greenish yellow discharge. Both of them have similar actions. They're both bacterial. They grow into the uterine tubes and cause scarring. They can grow into the urethra of males and females and cause, particularly in males, and cause scar tissue there. And depending on where penetration is taking place, it can even grow in the rectum and the anus or in the mouth. So we saw a large spike in gonorrhea during World War II in the 1940s, We saw another spike here in the 60s and 70s, and then it dropped down until lately there's been an increase here. And again, it's our, the largest concentration is in our southern states here. So this is the discharge I was telling you about. Notice there is a greenish yellow discharge right here, a creamy greenish yellow discharge coming out of the urethra. So this is the identifier. It's more distinctive than what you see with chlamydia. The good news is that both of those are very easily treated with antibiotics. If they're caught early on, there is no problem later on, because you're not going to get the, in the male, it'll be scarring of the urethra. In the female, you'll have scarring in the uterine tubes. Now, here is a case of an individual who has gonorrhea of the rectum from anal sex. And what's happened, of course, is that the bacteria has been introduced into the rectum. We have scar tissue. We've altered the shape of the rectum and the sigmoid colon, the colon below your large intestine. You have the ascending colon on the left-hand side, transverse across the top, and that big one on the right is the descending colon, and that goes into what's called the sigmoid colon, and that leads to the rectum and then the anus. And we see we're distorting the shape of this. So simple defecation would be very painful in here. So you've got this growth occurring. So the third type of STD is syphilis. Syphilis has also been around for a long, long time. It is also bacterial. Keep this in mind. Chlamydia and gonorrhea and syphilis are all bacterial, but syphilis uncontrolled can be fatal. Chlamydia won't kill your patient. Gonorrhea won't kill your patient. Syphilis will kill your patient given enough time. It is a spiral-shaped bacteria. It causes it occurs in 3 stages. The first stage of infection is, as I say, asymptomatic, but then a sore called a chancre will occur either on the surface of in most cases, the surface of the glands, or on the shaft of the penis, or on the labia around the vagina. And then it goes away. Your patient comes in with a sore spot, either on the labia or on the penis, and so I've been putting, some sort of antibacterial cream on this, and it started to go away. Well, that's great, but that's not going to get rid of it. It goes away because that's what these things do. They go in several stages. Once the chancre goes away, we move into the secondary stage, and that shows up about a month later, and your patient will have a rash. It spreads all over their body. They'll have joint pain. They'll have a fever. They'll feel miserable. And that lasts for about 3 months, and then it goes latent. And it may stay that way for the rest of their lives. It goes into a latent stage. If it happens to go into the tertiary stage, then that's the fatal stage, because now in the tertiary stage, the syphilis bacteria will cause lesions to occur in the central nervous system. We'll have the central nervous system start breaking down. Gaps will form in the brain and in the spinal cord. We will see lesions occurring in the heart. The heart will start breaking down. The bones will get weaker. The skin will start breaking apart, and then you'll die. So all because it was ignored. So, but that, it doesn't mean that everybody that gets syphilis is going to, doesn't mean that everybody that gets syphilis is going to die. The way you make your patient understand that they have to be treated is that this can kill you. It doesn't have to, but it can kill you if it goes into the tertiary stage. So we had this huge spike during the 1940s as a result of World War II. We saw a secondary spike in the early 90s, which makes no sense. And now we're starting to see an uptick again in here, in the late teens, and if I could get newer data, I would. But we're seeing a slight uptick starting in 2016. These are primary and secondary cases of syphilis. The latent syphilis, the tertiary, is running pretty low also. But again, if we allow the patient to go from the chancre to the sores to the tertiary, to the latent stage, we don't know if we're condemning them to death in 20 years, because we don't know if it's going to become a convert to tertiary syphilis in 20 years. Okay, this is the primary lesion that we see. Here we see in the glands of the penis, we have a great big lesion there, a great big chancre sore. That's what a lesion is, it's a sore. And we see it also there, right at the vestibule, below the vestibule and above the rectum. So the vaginal orifice is just above where the lesion is. So it's very, very, it's a very noticeable, detectable lesion. It goes away after a couple of weeks. It goes away, and oh, I'm fine, I'm better. Well, that's not the case. Secondary lesions here can occur, primary and secondary lesions. Notice we see chancres on the shaft of the penis there. We can see some pretty extreme secondary lesions, on the surface of the skin, on the face, on the hands, all across the torso, on the legs. These are all primary. The chancre sores are the primary lesions. And then these other sore spots are the secondary lesions, and they will all go away after about 3 months. So, but again, your patient isn't over it. Then we move into, if they go through the latent period and it becomes tertiary, then we move into this, where we have the skin rotting away, the bone dissolving. The central nervous system is being destroyed, and your patient dies. Probably with how badly they're infected, it's probably not a bad thing for them, because there's nothing you can do at this point. They can't recover from this. So once it's gotten to this stage. So, okay. Another condition. All three of these, so far, everything has been treatable. Everything has been treatable. Next condition, trichomoniasis. Easily treated. It's a protozoan, like parameciums or amoebas or things like that. The symptoms are very, very obvious here. It produces a very unpleasant odor from the vagina. So very noticeable. Further, the vaginal tissue develops some what they call strawberry spots. It looks like the surface of a strawberry, and and very, very easy to diagnose between the odor and the strawberry spots. It's easily identifiable. It's easily treated. And it doesn't cost much. It's inexpensive to treat this. It doesn't require the treatment for a protozoan is very easy for this to occur. It's sort of like, how can you not notice the odor? Because it is a very powerful and very unpleasant odor. Now, genital warts. Now we're moving into, okay, so we've seen the first three were bacterial. The trichomoniasis was a protozoan. Now we're looking at a virus. Genital warts caused by the human papilloma virus. A vaccine, injection of a vaccine for HPV will also prevent genital warts from occurring. Warts look like a little growth, looks like a little bump on your skin. A genital wart looks like a cauliflower, a little cauliflower there, and they tend to grow in clumps and they will grow together. Believe it or not, genital warts are the second most common type of STDs, with about 6 million new cases a year. A patient though with genital warts, even though it's caused by the human papilloma virus, is usually not going to get cervical cancer from it. The virus that causes the warts doesn't necessarily, or usually doesn't cause the cancer, cause cervical cancer. They look like this. These are genital warts here. They're clustered together. They look like cauliflower, or so they say. Maybe this does over here. We can see this is on the labia. Over here on the penis, we can see several warts occurring here. They are irritating. They can be painful during intercourse, and it's very easily spread. Now, untreated, it will grow. This mass of cells are genital warts, covering her mons pubis all the way down to the perineum, to the area directly below or directly above the anus, fully covering the vestibule and the vulva. This is one of those conditions where you say, well, you just didn't wake up with it one morning like that. I mean, how did someone let it get this bad? People do strange things. People tend to ignore conditions like this because if they either they're afraid to go in for healthcare, they're afraid they can't afford it, or they're afraid they're going to get bad news. Well, it's genital warts. It will get better if it's treated. Now, it is a virus. You can have these warts removed. The virus is there are no cures for viruses, and we can treat the symptoms. So the virus may be endemic in her system, or it may come back, but at least they can treat and get rid of the warts. So now another type of viral infection is herpes, genital herpes. We have, so we're on our second of the viral STDs. The herpes simplex virus has two categories, herpes simplex 1 and herpes simplex 2. If you've ever had a cold sore, you have herpes simplex 1. Once you have it, you always have it. So if you get a cold sore around your mouth, a fever, blister, you get stressed, like the corner of your mouth or something, that's herpes simplex 1. About 95% of the population or thereabouts has herpes simplex 1. Most people develop, usually around periods of time when they're stressed. A lot of stress leads to a cold sore. However, herpes simplex 1 virus is on the move. And it depends on type of sex that the couples are engaging in. The herpes simplex 1, the cold sore virus, can also infect the genitals. If a person is engaging in oral sex, for example, and they have a herpes simplex virus 1, a cold sore, they can spread it to the genitals of their partner, and their partner will get a lesion from herpes simplex 1. Now, the typical genital herpes virus is number 2, herpes simplex virus 2, simplex 2. This is the one that is spread through sexual contact, through skin-to-skin contact. It is very contagious. You can't catch it off of a toilet seat or a towel or a cup, but if you have an open sore, you can spread it to a partner, and it will, form lesions around the genitalia. So this HS2, simplex 2, is always been classified as the genital herpes, the sexually transmitted herpes. HS1 is the simplex 1 is what we get from, we pick it up somewhere, and see, and it lives. Simplex 1 is viruses don't live. Viruses are not alive, but the simplex 1 is usually contained in the neurons around our mouth. And so when we get stressed, the virus migrates to the surface of the skin and causes a lesion to grow. Same thing applies to the genital herpes. Simplex 2 exists in the neurons around the internal and external genitalia, and under stress or during intercourse or exposure to sunlight, that's one of the triggers, it will also manifest itself. And so now your patient has active genital herpes sores, lesions, and if they engage in intercourse with someone else that's not infected, they likely have infected them. So, okay. Simplex 1, cold sore. This is actually a student of mine about 8 years ago. And I want everybody to see my cold sore. No, it's herpes 1. So, okay, fine. So I put it in that. But that's what, if we probably, if you've ever had one, you know what I'm talking about. I always get mine in the corner of my mouth when I get stressed. This is a typical cold sore. It comes out and it goes away. Viruses will manifest their condition over a 14-day period or thereabouts. It takes about 14 days for our immune system to get activated to knock it back down, and then it goes away. Just like the flu. You get exposed to the flu, you get sick, you're going to be sick for about 2 weeks. You're going to start feeling better about somewhere around the end of the first week, and you'll keep feeling better until it's gone, because it took that long for your immune system to kick in and produce antibodies to fight the infection. And so when you get a cold sore on your mouth, simplex 1, it goes away in about 2 weeks. Same thing with genital herpes. They go away after about 2 weeks. People that have genital herpes, only about 15%. Very few people actually manifest the symptoms at any one time. It will flare up, though, on unusual triggers, including the 901 area code. Who knows?
That's not suspicious or anything.
Oh, no, not at all. Maybe it's that if you saw those emails that went out the other day about
The spamming.
the spam. It's a spam call.
901 area code is Memphis.
Memphis. Ooh, there we go. That just fills me with such security. So now there are lots of triggers. A person with genital herpes will have a trigger for who knows, whatever the trigger will be. Sometimes it's walking out in the sun on a nice day and it's like, there they go, they flare up. You know, and it's, you know, often if a patient who has genital herpes, because they don't go away, you don't lose the virus. The virus still maintains itself in the nervous system. And, you know, it just, intercourse can trigger the lesions forming. Stress can form it. So any number of things. We do see a lot of simplex 1 showing up in the genitals now, because there's been a real, there's been a gradual rise in the increase in oral sex, particularly among younger children. Middle school age students have, there's a real spike in oral sex practices in middle school age students, and a rise in herpes simplex 1 and 2 showing up, you know, where 1 shows up in the genitalia, 2 shows up in the inside of the mouth or around the mouth, because middle school children, a lot of them have this belief that oral sex isn't real sex. So,
I think I'm pretty sure I was still like Barbie dolls in this way. Anyway.
well, there you go. But you know, my wife teaches at the intermediate age and at the middle school age, and there are, you know, you have such a wide range of students in the middle school, you know, and it's, I can understand those statements where you talk about, you know, oral sex. And so there's been a lot of migration of these viruses spreading apart here, spreading, you know, where the cold sore virus is showing up in the genitalia, and the genitalia virus is now showing up in the mouth and in the nasal cavity, things like places like that. Where it causes a real problem is if the virus is passed on to the developing baby, and it can damage development of the baby in utero. So again, it's a virus. It doesn't go away. It just lapses into a latent period and then comes back out again. So there are no cures for viral diseases. You can treat them. There are antivirals that will knock them down and reduce their impact, but there is no true cure of a viral disease. And this is what the type 2 lesions look like, you know, whether we're on the labia or on the shaft of the penis there. They're both very prominent, and they just look like they're going to hurt anyway. So, okay, that is the end of the reproduction chapter. And let's see. Let me stop sharing for a second. Let me take a look and see.
And you said Monday that we didn't have to worry about lab exams this week.
No. But don't forget, Monday we will be dissecting the cow heart in class. So.
Will exam for the Thursday lab exam be open after that?
Yeah. Well, I want you to enjoy cutting things up. So. Let me take one look here. Here we go. Okay. What we'll do is on Monday in lecture, we'll start here on chapter 28, pregnancy and development. And then we'll go on into that, and then we'll be done with unit 2. So. This, believe it or not, while it says it's 120 slides, we're going to go really fast here because many of these are just, these slides are images of growth of the baby up until birth. So, but we'll start with this in lecture on Monday. Lab on Monday, of course, is the rest of the heart and dissection of the heart. So I'm supposed to get several hearts tomorrow, so we'll see how that goes. So, okay, let me get us out of here and Did I stop us already? There we go. Okay, so Monday we'll pick up on pregnancy and development. Lab Monday afternoon will be the heart, and I encourage anybody that is normally Zooming, if they want to come in and get messy, to come on in. So.